Hi, in this session we'll be talking about how we treat thrombotic episodes, and they're clots that occur both in veins and arteries, and there are particular diseases that are associated with those patterns of clot formation depending on the location and the organ involved. If you haven't watched Introduction to Hemostasis, I'd strongly advise that you go back and watch that video because it will really set a foundation for understanding how antiplatelet, anticoagulant and thrombolytic therapy has its effect on the hemostasis pathway. So the learning objectives for this particular session are understanding the aetiology of arterial and venous thrombi. I'm not going to go into that in too much depth because you could do a whole talk on individual diseases there, but I'm going to link the physiology with the pathophysiology of those thrombotic conditions in particular disease states. Understanding that will help us understand the role for antiplatelet, anticoagulant and thrombolytic therapy. Then we're going to understand how those agents work to prevent or treat thrombosis, and you'll be maybe surprised to find that a lot of the agents are less about treatment and more about preventing further complications from the event and then occurring secondary events down the track. And finally, we'll talk more about thrombolytic therapy and how that actively treats and dissolves thrombus in certain disease states. So just to revise hemostasis, it's good to break it down into primary hemostasis, secondary hemostasis and fibrinolysis. The primary element is the platelet plug formation when there's damage to an endothelial wall within any vessel, whether it be vein or artery. And then secondary hemostasis is where the fibrin mesh binds those platelets together. It cements the clot so that it can persist for more than a few minutes or hours. And then finally, when time has passed and the clot has served its purpose, there is a natural physiological state of fibrinolysis through the endothelium releasing factors that activate plasmin and dissolve the clot. And this is a visual representation of that occurring. So thrombus happens. Why and how do these particular clots occur? So you can't talk about clotting without talking about Rudolf Virchow, who was a German physician and often called the father of pathology, who lived in the 1800s. And he did some really important work that we still base our understanding of today. And Virchow's triad of hypercoagulability, endothelial injury, and the stasis of blood flow is still the foundation of our understanding of clots today. And both of those can occur in terms of arterial and venous thrombosis, but we mainly use Virchow's triad in terms of looking at all of those factors within venous thromboembolism, but they still do apply somewhat within arterial thrombus. If we talk about venous thromboembolism, or VTE being the term that covers all of those conditions, we mainly think about deep vein thrombosis, or DVT, and pulmonary embolism, PE. It was actually Dr. Virchow who came up with the condition or the term thrombus and thromboembolism. And if you're not familiar with that, thrombus is simply a clot formation. So there's a trigger at a local vessel for a clot to occur because of damage, either external or internal. The clot occurs to protect the lining of the vessel so it can heal. It's a physiological state, and sometimes that occurs excessively in disease states or in the presence of medications. So embolism is where there is some kind of substance, and it can be a clot. That's where it's a thromboembolism. So there's a thrombus that has occurred, and a piece of that breaks off in the bloodstream and travels to another organ and lodges there, causing damage. The two classic examples of thromboembolism would be in venous thromboembolism, where we have a DVT or a thrombus potentially in the leg, one of the veins in the leg, and a part of that thrombus breaks off and then travels up, goes through the right side of the heart, and then once it finds an area that narrows down in the vasculature of the lung, it then causes a thrombotic effect there. That's called a thromboembolism because the thrombus came from somewhere else and then lodged into a different organ. The blockage there then results in hyperperfusion and damage to the lung. That's a PE that can present with hypoxia and chest pain classically. If it's large enough, it can block off multiple arteries and can be life-threatening, causing a cardiac arrest. On the arterial side, the other classic example I think of is atrial fibrillation. So in the atrium of the left side of the heart, there is a disorder of blood flow because of the erratic nature of atrial fibrillation and the lack of a regular atrial kick that is emptying the atrium of blood. And the irregular blood flow results in a hypercoagulable state and a thrombus formation either in the atrium or in the left ventricle itself in some cases. And then parts of that thrombus can break off and they can go to almost any organ that has an arterial supply, which is all of them in the body. And the classic one that we want to prevent is stroke. And that's where the thrombus embolizes up through the carotids and into the circular Willis and then lodges itself in one of the main arteries within the brain and will then present with neurological deficits related to the area of the brain that it's blocked circulation off to. So that's thromboembolism, and that whole term was actually coined by Dr. Virchow himself. When we look at VTE, the two major elements here are the stasis and the hypercoagulability. So definitely endothelial injury does play an important role. The main processes that I look at are stasis and hypercoagulability. Stasis is relatively easy to classify. You think of being immobile due to travel, so classically people on long distance flights, but it can happen on long distance driving, which in Australia is a really common thing to occur, although a little bit less now that we're in the COVID pandemic state with a lot of lockdowns. And then you can have immobility due to injury. So maybe someone has injured their leg or had a fracture and it's been casted. The usual movement of the muscles in that leg would usually move the blood up through the venous system back to the right side of the heart. And there are a number of valves in the veins that help support the direction of that blood flow. But if you're not using your muscle, the blood flow isn't being moved very well at all. It's a very low pressure state and thrombus can occur there. And the similar thing happens with immobility due to surgery. Surgery itself will have an inflammatory component causing hypercoagulability and the stasis from having a general anaesthetic and then often having bed rest for at least the next day after surgery. So they're the common areas of stasis that I consider when I'm evaluating a VTE event. And then there's a lot of triggers that can have a hypercoagulable state. So think of lots of different causes of inflammation, whether temporary or long-term. Medications, classically the oral combined contraceptive pill. Thrombophilic conditions, so that can be factor V Leiden or prothrombin gene mutation, factor C and factor S deficiencies, antithrombin deficiencies, or even acquired conditions like antiphospholipid syndrome. Cancer has a very prothrombotic effect, one that we're understanding more and more as years go by. Pregnancy is also a hypercoagulable state, nephrotic syndrome, and obesity, just to name a few. There's more rarer ones, but they're the ones that I'd always be thinking about. And then there are arterial thrombi. And the classic occurrence here, other than atrial fibrillation, which we've talked about, and atrial fibrillation is mediated primarily through this hypercoagulability from the disordered blood flow in the heart, is atherosclerosis. And that's where a thrombus occurs in response to an acute endothelial injury or a plaque rupture that then causes hypercoagulable state. There's a lot of things that predispose that, and you could talk about that independently, and hopefully you've got talks on that you can access. But endothelial injury, I think about smoking and hypertension, hypercholesterolemia, and diabetes mellitus, and the formation of these macrophage foam cells with cholesterol underneath the endothelial top layer, and then stenosis of those vessels, particularly in coronary arteries. So atherosclerosis can occur anywhere. It's what causes some strokes, it's what causes heart attacks, it's what causes peripheral vascular disease, as well as other diseases of other organs in terms of microvessel damage. So you've got this already narrowed vessel, and then you've got a plaque, and when the plaque ruptures, you might remember one of the primary triggers, other than collagen, for platelet plug formation and thrombosis occurrence is tissue factor. And so tissue factor is so essential in the pathogenesis of acute plaque ruptures, because those atheromas with the macrophage foam cells are rich in tissue factor. So not only does that part have this big release of tissue factor, more than would usually be there in a healthy endothelium, you've also got elevated levels of tissue factor that are circulating. And so both of those things, you've got this underlying hypercoagulable state, and then when you get a plaque rupture, you get a massive, inappropriately excessive activation of thrombosis through that tissue factor exposure, as well as the collagen, which is healthy. Smoking itself and thrombophilic conditions can just add more fuel to the fire for that hypercoagulable state. So if you want to see some of this, particularly the atherosclerosis pathway, again, I'd recommend Thrombosis Advisor has some great video representations of these processes, and I'll just put the link here if you want to watch that just for 1 to 2 minutes to see the picture. So what medications can we use to treat thrombi when they occur, and what's actually the goal of that therapy? So if we look at the different elements of hemostasis, primary, secondary, and fibrinolysis, there are medications that specifically target each of those processes, and there's very few that actually target more than one process, which is one of the major exceptions to that rule is a drug called bivalirudin. It has both an anticoagulant and an antiplatelet effect, but almost all of the other drugs either are antiplatelet, anticoagulant, or fibrinolytic agents. Thinking about the triggers of the clot, there are a few that we can target with drugs. In terms of antiplatelet therapy, there is acute thrombosis, and what we're doing when we give antiplatelet in that setting, so let's say someone has a myocardial infarction or a stroke, we're giving them antiplatelet agents, and you might think the antiplatelet agents will dissolve the clot, but they actually won't. What they're doing is they're preventing extension of that acute thrombus, or even embolization in the rare occurrence that it's happened that's not at the end of the vessel. That's what it's doing there. It's kind of stabilizing the clot so it doesn't get any bigger. If you actually continue that antiplatelet therapy, which most of the time you will, what you're really doing is doing secondary prevention. An event has occurred with a thrombus and you want to reduce the chance that another event will occur because they're much higher likelihood to do that. And that is the case in cardiovascular disease or cerebrovascular disease or peripheral vascular disease. The role of the antiplatelet agent in the acute setting is to prevent extension of the clot, and the secondary element long-term is to prevent recurrence of those clots. So you think about the classic antiplatelet agent, it's aspirin, also known as acetylsalicylic acid. This was the original one that was found, and it was previously used for headaches, and it's still useful for headaches, but out of all of the non-steroidal anti-inflammatory drugs, or NSAIDs, it's aspirin that has the strongest effect on cyclooxygenase 1 in terms of its antiplatelet effect. Other NSAIDs do have a mild antiplatelet effect, but not to the same extent. So within the platelet, if you remember that picture before, we could see that there's signal transduction, and once a platelet becomes active, it activates arachidonic acid, which then activates cyclooxygenase 1, with a peroxidase being a cofactor, which then produces thromboxane A2, which is released and triggers other platelets. So aspirin inhibits the cyclooxygenase 1, which ultimately means you are not producing the same quantities of thromboxane A2, and you are getting less activation of other platelets nearby. Still, you get some, it's just moderating that effect to be less in the presence of aspirin. Once aspirin binds to platelets, it's actually irreversibly bound. So once the platelet's produced, it binds to aspirin. Forevermore, that platelet is less active than it would usually be because of the binding. There's a number of trials if you're interested, and that's not the focus of this talk, but the original trial was a Veterans Affairs study done in 1983, well before I was born, where they used higher dose aspirin, or 324 milligrams, very bizarre kind of dose, versus placebo in men that have unstable angina, plus or minus a previous MI. And they actually found there was a 51% reduction in recurrence of MI in the future. So they went from a rate of 10% for patients would have a recurrent MI to 5%, which is one of the biggest reductions in events that we've ever seen. And so that showed that the number needed to treat in terms of people that have MIs, if you give them aspirin, if you treat 20 people, you will prevent 1 myocardial infarction. Following on from aspirin, some years later, around I think it was the mid-90s, we came across another drug called clopidogrel. Clopidogrel was another antiplatelet agent. It was more efficacious than aspirin, but naturally anything that's more efficacious in antiplatelet or anticoagulant activity naturally has a higher bleeding side effects profile, which clopidogrel does. We found that we could combine clopidogrel with aspirin, or we could use clopidogrel instead of aspirin, and generally it was superior in terms of events. So we've generally used this in terms of secondary prevention. And if someone has an aspirin allergy, you can switch them to clopidogrel. Clopidogrel actually is actively metabolized by cytochrome P2C19, not that you'll ever be examined on that, but so it's a prodrug that produces an active metabolite, and the active metabolite binds to ADP receptors to prevent ADP, which is released to activate other nearby platelets, from activating those platelets. So you can see how it works well. It's irreversibly bound, like aspirin, so once a platelet's been exposed to clopidogrel, it will be less active than it was prior. There's a number of different trials, and the interesting thing about all of these trials is they all start with C, like Capri, Cure, and Credo, and they've shown in a number of different vascular diseases the role of clopidogrel being very effective. Ticagrelor is the newest antiplatelet that we use commonly, as often replaced the role of clopidogrel as a second or replacement antiplatelet agent in combination or instead of aspirin. Ticagrelor has a faster onset than that of clopidogrel and has a high efficacy, although still a slightly higher bleeding rate than clopidogrel, unsurprisingly. But overall, the balance seems to be that it's better to use ticagrelor than clopidogrel for acute myocardial infarctions. So clopidogrel is still being used in terms of peripheral vascular disease and cerebrovascular disease, but it's ticagrelor that has often replaced the role of clopidogrel, particularly when it comes to putting stents into coronary arteries. The two major trials that, if you're interested to look up on ticagrelor, have been the Plato trial in 2009 and the Pegasus trial, which was a longer-term use of ticagrelor in 2014. Both of them found significant benefits. Those are the main ones that I'd recommend you think about in terms of antiplatelet agents, and the ones that you'll see really commonly and prescribe even as a junior doctor: aspirin, clopidogrel, and ticagrelor. So knowing them is a really good thing to read up on. But there are some other antiplatelet agents that you may see used in some areas, particularly in terms of cardiovascular interventions. This is when they're doing an angiogram to put in a stent. They often use other antiplatelet agents acutely as an infusion to reduce the chance of in-stent thrombosis or events whilst they're actually doing the angiogram. So one of the first ones of these was abciximab, which is a monoclonal antibody against that glycoprotein 2B3A, that really important receptor where fibrin binds and cross-links the platelets. So you can see why targeting that would be really efficacious in preventing further thrombus formation. So we generally have only used that for percutaneous interventions, which is where you put a stent into a coronary artery. There's another one that is a similar kind of role in terms of PCI use, which is tirofiban. Tirofiban is also an infusion or an intravenous injection that affects the glycoprotein 2B3A receptor, and it has a very short half-life of only 2 hours. So it's rapid onset and then rapid offset, which is really useful in the interventional setting. So you can see here, to summarize, if we go back to a picture of the platelet, you can see a number of areas where we've used our different drugs to target the processes that are occurring here. So you can see that there's the P2Y12 receptors there. Ticagrelor binds in a reversible state, whilst clopidogrel binds in an irreversible state. You can see aspirin's effect on cyclooxygenase 1 at the bottom. You can see abciximab and tirofiban's effect on the glycoprotein 2B3A receptor there that would then prevent fibrin from cross-linking them. And you can even see some of the effect of anticoagulants on thrombin. Thrombin primarily is about fibrin activation, but it does have a role for activating platelets as well. Let's move now into anticoagulant therapy. In terms of the role of anticoagulant therapy in acute thrombus, whether it be arterial or venous, it's about preventing the extension of that acute thrombus, much like antiplatelet therapy, and to prevent the embolization of the thrombus, and that's particularly in the setting of venous thromboembolism. So if you've got a DVT, you give people anticoagulant therapy to prevent the clot from extending further up the leg or arm and to prevent it embolizing to the lung. In terms of its ongoing use, once the thrombus is actually dissolved, there are many settings where you would continue the use of an anticoagulant to prevent further episodes down the track. And that would be the most common indication for anticoagulation therapy is atrial fibrillation, where you've got an ongoing risk of the hypercoagulable state and having a systemic arterial emboli going to an organ, particularly the brain, and having a stroke. So we use it long term there. And then we may use it in some instances for a few months to prevent recurrence of a DVT or PE. And in some cases where they've had unprovoked VT events or they have a thrombophilic condition, we use it long term, either in full or reduced doses, to prevent the chance of that recurrence in future. So within anticoagulants, I've summarized them here. The first one you should really understand is heparin. Heparin doesn't actually have a direct effect on thrombin or on the procoagulant factors. It affects them through antithrombin. Heparin binds to antithrombin, and antithrombin itself has a kind of a round structure where the binding site is internal. And when heparin binds to that antithrombin molecule, it opens up and it becomes 1,000 times more active and more efficacious at binding to activated factors. I think of antithrombin kind of like the cleaning up tool, because you can't just have all of these activated factors sitting around until they eventually just denature as proteins. You need something that balances the rate of activation with the rate of clearance, and antithrombin is the major molecule that does that. There are others as well, but antithrombin is the main player. Antithrombin has its most effect on thrombin itself, so cleaning up thrombin, activated 2, as well as cleaning up activated 10A. And so heparins will actually activate that. Unfractionated heparin, which is just a pure heparin infusion, has a bit of a balance effect on thrombin plus 10A, whilst low molecular weight heparin that can be given intermittently via subcutaneous injection has more an effect on the 10A than the thrombin itself. In terms of vitamin K antagonists, this class is dominated by warfarin. Like we mentioned before, there are factors 2, 7, 9, and 10 produced, like most factors are, in the liver that are dependent on vitamin K. And so even though we call these a vitamin K antagonist, they don't directly antagonize vitamin K. They actually inhibit an enzyme that helps recycle and reactivate vitamin K after it's been used. And through that process, that inactivated vitamin K gets disposed of in the body, and the body loses all of its vitamin K and therefore cannot produce replacement factors of 2, 7, 9, and 10. Through that, it reduces the effect of thrombin activation and therefore has an anticoagulant effect. We still use warfarin today, although warfarin for many indications, including venous thromboembolism and atrial fibrillation, has generally been replaced with some of the new agents, which I'll talk about now. My favorite anticoagulant is apixaban, and it has another relative called rivaroxaban. They are anti-10A molecules, and they therefore prevent 10A from binding to prothrombin and produce thrombin. Obviously, there's still some thrombin formation, but it reduces that effect. You can always remember that they have an effect on activated 10A because they have the XA within the name of themselves, xaban. So you can think of it binding to 10A. Then the other one that you'll see used sometimes is dabigatran. Dabigatran, again, is an oral therapy that has a direct thrombin inhibition. So it's an anti-2A drug, and it has a reversal agent available in Australia, which is why sometimes it's a more attractive option over apixaban and rivaroxaban, even though its rates of thrombus prevention are slightly lower and its rates of bleeding are just slightly higher in some organs. So if we return to the coagulation cascade, we can have a look at how these drugs actually affect the different elements of the cascade. As I said before, I don't need you to remember all of the elements and which factor activates which. All you need to know is that there's an intrinsic pathway and an extrinsic pathway, and that tissue factor is involved in the extrinsic factor pathway. And that tissue factor is involved in the extrinsic pathway, whilst collagen and other factors are involved in the intrinsic pathway. Eventually, they all lead to factor 10 activation, thrombin activation, and fibrin activation. So you can see here that apixaban and rivaroxaban have their 10A effect that will reduce thrombin formation. Warfarin affects 2, 7, 9, and 10, so you can see that it affects majorly the intrinsic pathway, but it also affects parts of the extrinsic pathway and the common pathway. And then you can see that heparin and enoxaparin have their effect on antithrombin to then accentuate the effect of antithrombin on 10A and thrombin clearance. And finally, dabigatran has a direct thrombin inhibition effect. So that's anticoagulants and antiplatelets. Let's finish now on thrombolytic therapy. So this is directly where we are dissolving the clot. And again, a bit like heparins do it through accentuating a physiological process. Our fibrinolytic therapy also accentuates the physiological process. And this happens only in the case of acute thrombus, which is going to be threatening to someone's life or major organ damage. So we generally use it in the case of heart attacks, where you can't use a percutaneous intervention approach, and we use it commonly in strokes where they presented within the first few hours. So we haven't highlighted very much about fibrinolysis, but fibrin itself has been formed and it's then bound to the platelets, and it releases some fibrin degradation products. We can actually measure those. So if you've ever seen D-dimer, D-dimer is a fibrin degradation product that we can measure clot formation through D-dimer. Then if we have plasminogen, which is the genesis of plasmin, the activation of plasminogen, usually through tissue endothelial factors, they will activate that into plasmin, and then the plasmin will directly dissolve the fibrin and the platelets come apart and the whole clot dissolves. That will happen physiologically, and so when we use anticoagulants and antiplatelets and nothing else, we're effectively preventing that clot from getting any bigger or going anywhere, and then we're just giving time for eventually the endothelium to release tissue plasminogen activators, produce plasmin, and the plasmin will dissolve the clot at the right time. But in some cases, we know that inappropriate thrombus has formed. In order to rescue that organ or even sometimes the person's life, we need to use more active measures to increase the concentration of plasmin and dissolve those clots. That's fibrinolytic therapy. The common groups that we use are tissue plasminogen activators. And the ones that you'll see used around these days all end in plays. So alteplase, retaplase, and tenecteplase. I'm more familiar with alteplase and tenecteplase in terms of where I work. So these are enzymes that catalyze the conversion of plasminogen to plasmin, and plasmin itself is a serine protease that dissolves the fibrin within a clot. If you've got venous thromboembolism, we'll always use anticoagulant therapy, but in some cases, like a massive and life-threatening pulmonary embolism, to prevent a cardiac arrest or damage to the lungs, we might use thrombinolysis in addition to dissolve that clot really rapidly. In terms of arterial thrombi, we use anti-platelet therapy, often dual antiplatelets initially. We often add anticoagulant therapy to that, so we're inhibiting both primary and secondary coagulation to stabilize that clot and prevent extension and embolization. And then we will use thrombolysis in certain indications like acute stroke or ST elevation myocardial infarction, where we can't access percutaneous intervention or percutaneous intervention is not possible to dissolve the clot. And if we've got limb ischemia, we often use thrombolytic therapy there, which we can often use through interventional radiology with a catheter to actually put the fibrinolytic therapy directly onto the clot and try and reduce systemic effects through that means. Of course, with the most potent and efficacious anti-clot effect, you would assume there's going to be a high bleeding risk. And that's the payoff here. Even with a stroke, there'll be a risk that we use fibrinolysis and then that results in a bleed in the brain, which is also quite disastrous. So we have to be very selective with our use of the thrombolytic therapy in those that will have a manageable bleeding risk. And if people have often a past history of bleeding or have other factors that are making them pro-hemorrhage, we generally can't use fibrinolytic therapy because of the bleeding risk that's there. So hopefully now at the end of this talk you've understood the role of antiplatelet agents, anticoagulant agents and fibrinolytic therapy in terms of both venous and arterial thrombi.